Good morning everyone, and on behalf of St John of God Murdoch, I'd like to welcome you all here today to our patient education session on common issues you may find within children regarding ENT. My name is Wendy Singleton and I'm the nurse manager for St Michael's. St Michael's ward is our paediatric ward. We have 30 beds there to cater for children undergoing a variety of surgical interventions. We have a highly skilled paediatric team on there, so they will help care for your children while you're with us. We see a variety of surgical procedures ranging from general surgery, urology, orthopedics, gastroenterology, and of course ENT. We also offer all-inclusive packages for our ENT children as well. We are extremely honoured and we're proud to have both George Sim and Heaney work with us here at Murdoch. George is also our head of department for paediatrics, and Mairead has a very extensive history in anaesthetics with children. So without further ado, I'll let you hear the reason why you're here and hand over to George.
Thank you, Wendy. And thank you for coming in on a Saturday morning to listen to us. Before I start, I'd thank Olivia and Matilda for organizing this series of talks, which is really good. As Wendy said, over the years, we've developed the whole pediatric service here at Murdoch, starting from a tiny little ward and slowly gathering all the different specialties together. And finally, we have a bright, airy, really nice 30-bed unit with a very comprehensive range of specialties to take care of your kids. And slowly over the last 2 years, I thought I'd like to share with you one of the programs that I'm doing with the hospital and with my anesthetist, which is our community and social outreach program to help kids who are within the South Metro area, providing early screening of their ear diseases and provide early intervention here on-site in the hospital, where we provide their grommet surgery at no added or extra cost to the families at all. So far, we've been having 15 kids per year for the last 2 years. So something that we're certainly very proud of. This is just a picture of a couple of families coming in and early pickup of their ear diseases with Peloton Kids Institute. And I do the consulting at Coburn Integrated Health. So moving on to the talk itself. Sorry, I jumped the gun there. So we're going to talk about common pediatric ear, nose, and throat conditions. There is a wide range, but given the limitations of time and what we can discuss today, I thought we limit to what commonly occurs in a young child. So starting off with the ear, just to refresh our memories about what the ear is all about in terms of anatomy. With the outer ear starting from the pinna, which is over there, into the outer ear of the ear canal, and that ends at the eardrum right there. So the eardrum forms a wall that separates the outer ear from the middle ear and the inner ear cavities. I guess our main area of concern here today would be the middle ear. Because middle ear infections is the most common ear infections in kids. We do get outer and inner ear ones, but that tends to be more rare. Middle ear would be between the eardrum and the inner ear structures. Contained within that are your 3 hearing bones and the nerve that moves your face. There's one ventilation pathway which I thought we should all be aware of, because that leads to our common middle ear infections. So in little kids, the main problem is their eustachian tubes are very tiny, they function very poorly, and they lie at a very awkward flat angle. So very often then when they get infection in the upper respiratory areas, the infection travels very quickly up the eustachian tube into the middle ears, and therefore trigger off the ear infections. Gradually, as the child grows, the caliber of the eustachian tube widens, it becomes much bigger, and the angulation goes from a flat angle to that. And therefore, as kids get a little bit older, the incidence of middle ear infections becomes less and less as the child grows. Sorry. The eardrum provides a window as to what the middle ear condition is like. It gives us a clue because beyond the eardrum, we can see what the middle ear looks like. So starting off with a fairly normal looking eardrum, when you look in there, it's like a disc. The disc should be intact and it should be kind of crystal clear. And with it, when you shine a light in there, there's usually a light reflex that's clearly visible. And usually you'll be able to see the first hearing bone. The name of that bone is called the malleus. And as you can see, it's fairly normal looking. Starting from this, I'm going to show you a couple of abnormal looking eardrums. Middle ear infections can be classified into three main types. You have your really acute bad ear infections that's easily picked up by yourselves, and that's called acute otitis media or your acute middle ear infection. Sometimes it can go under the radar. It goes on a more prolonged course, it becomes a bit more subtle, and this is what we call glue ear at times, but otherwise known as your otitis media with effusion. And lastly, the yucky discharging one with pussy discharge pouring out from the ear, which is your chronic suppurative otitis media. Acute middle ear infection tends to be more obvious to you as parents because the child will be in pain, they'll be irritable, they'll be crying, they'll be pulling their ear, they'll be unsettled. They might go off their feet, they might sleep poorly, they'll go off their feet, they're really unhappy. So when that happens, you start to think about starting pain relief. Get the child comfortable, see how your child is. But if symptoms fail to settle, normally you end up seeing your GP. So if you recall the normal looking eardrum compared to this one right here, when your GP looks in, it'll be angry looking, it'll be red, normally bulging. It's bulging because the middle ear cavity is only so big. There's no room to expand. And when the infection builds up, you get lots of infected fluid in the middle ear and thereby pushing the eardrum outwards. So when that happens, it is really uncomfortable with lots of pressure. And if the fluid is infected, this is where you get your temperatures. And being quite limited in its volume, as the infection progresses more and more, you might get a bit of discharge from the ear. That's because the powerful least resistance, the easiest way out for the pus is to burst through the eardrum, cause a perforation in there, and this is where you might see a bit of discharge from the ear. So there are a couple of known predisposing factors as to why a child gets increased middle ear infections. Daycare, more exposure to your bacteria and viruses, smokers in the house, kids who are born premature with very low birth weights, kids with known reflux, and of course there are certain kids with sort of your syndromic kids with craniofacial disorders, they'll be more prone to getting middle ear infections as well. On top of that, there'll be feeding related issues like using the dummies all the time or baby that's on the bottles all the time. There's this sucking motion, this constant reflux outwards. Acute middle ear infection tends to present more in little ones, so mostly in kids under 2. You still get it in older kids, but it tends to be more common in the younger age group. So management of acute otitis media would be starting off with your regular pain relief, get the child really comfortable. You go on a regular regime of paracetamol and ibuprofen and keep that going for a day or 2. But if it fails to settle with that, if the pain persists for 2 days or more, if there's a development of temperature, that could suggest it's gone systemic, and therefore you make a trip down to see your GP. So normally then in situations like that, you end up with a course of antibiotics. Normally the antibiotic of choice would be amoxicillin. You go that twice a day and you keep that going for about a week or so. Generally, the course of acute otitis media will be between 7 to 14 days with gradual improvement along the way. If it becomes excessive, this is where you start to think about perhaps it might be a good idea to discuss with your GP about seeing an ENT surgeon. And the guidelines will be roughly about 3 episodes in 6 months or 4 in a year. This is a very common type of ear infection. It is a middle ear infection that is going chronic. It's at least 6 weeks or more, if not longer. Given it is a little bit more subtle, the symptoms are less severe, and therefore sometimes it goes under the radar, you might not pick it up as well. There's no obvious pain and there's no obvious temperature. More so, it results in fluid retention in the middle ear, and that fluid is sterile. It doesn't flare up usually, and therefore as more and more fluid builds up over the course of time, the child ends up with slight hearing loss. And as more and more fluid gathers in there, the hearing loss gets worse. And therefore the impacts on the child when it eventually presents to you could be in the form of speech and language delay. They could lose their clarity of speech because whatever goes in that's a little bit unclear, coming out the other end, as you can imagine, will be unclear as well. Some kids will have quite a fair bit of pressure in their ears, not quite outright pain, but it's pressure in their ears and therefore they're uncomfortable, they're pulling, they're tugging at it. A little one might be irritable once again, but because they can't hear very well, they could end up with problems at school, they can't concentrate that well, they're a little bit scattered, and they can end up with behavior problems as well. Part of the workup in a child with suspected middle ear effusion would be to get hearing tests done. So what we see is what we suspect, but in order to chart the severity, this is where we do a hearing test. So in my rooms, I have pediatric hearing testing facilities with my own pediatric audiologists. So they're able to get a whole different range of hearing testing done according to the age or presentation of the child. Brackets, normally you see something like that, the end result hearing test. You see brackets. Brackets would suggest the baseline hearing level of the child, how well the child can hear. So we do that by stimulating the bone at the back, which then transmit that vibration to the cochlea, which then stimulates their hearing nerve and gives us their baseline hearing level. But very often in the child with glued ears, they actually don't hear that well. So you have crosses and circles on the bottom line. That suggests the hearing from the left and the right ear. So you can see a gap between the two. That gap is created by that fluid sitting in the way. So that fluid prevents the eardrum from vibrating, and therefore when it doesn't vibrate as well, sound transmission gets a bit impaired, and therefore you end up with what we call a conductive hearing loss. So normally when that happens, you start to think, oh, what to do? It depends on the child. If a child is fairly asymptomatic, meaning they're plodding along fine, no excess pain or discomfort, and their speech and language capabilities are pretty acceptable, you could wait and see. So wait and see is an option. And while you wait and see, there are other described the methods you can do to help improve the situation, one of which is known as an autoinflation device. It can be challenging. So the rationale behind this is trying to increase the whole nasal pharyngeal pressure in the head, and thereby transmitting that pressure all the way into the eustachian tube, stent it open, and hopefully and pray that fluid will drain down that tube. It may or may not work. It can be challenging because trying to get your kids to do that would be quite tough, right? So the aim is to cover one side. It has a nose piece there, right there, attached to a balloon. So you inflate, and then as the balloon deflates, keep it in there. So it works both ways. As you blow it up, stents it open, and as the balloon deflates, it stents it open. 50% chance that this might work, but if you want, you can give it a trial. One example of autoinflation device is the autovent balloon. You can get it online. So you'll be wondering, should I start antibiotics? Should I use nasal sprays? How about antihistamines? You can try all that. But chances of it clearing would be very low. It's limited role from our studies of all the above to try and clear that middle ear fluid. Unless if the middle ear fluid is really acutely infected. So you get your pain and your temperature, antibiotics might work, but otherwise it doesn't help to clear. You can wait and see. As I say, if your child is fairly asymptomatic, you can wait and see how it all goes. But a lot of times, as time goes along, as more and more fluid set in there, that fluid becomes really compacted, thick, and sticky. And therefore, when it gets to that stage, the tendency to clear down the eustachian tube becomes really low. And because of the consistency of that fluid, thereby the term fluid is. And because of that, the sticky fluid stuck to the eardrum all the way into the middle ear, and therefore it doesn't vibrate. And therefore, if everything fails to settle, and in order to prevent any further speech and language impairment and behavior issues, grommets is an option. Grommet creates another ventilation pathway through the eardrum, and thereby bypassing the eustachian tube. And therefore, grommet has another name that we call a ventilation tube because it creates that other ventilation pathway. As you can imagine, pretty much all kids' procedures are done under general anesthetic. But for grommet insertion, it is a quick procedure, day case. Your child stays for about an hour after the procedure, and we'll wave goodbye to you, and you'll be on your way home. Quick procedure, generally about 15 to 20 minutes. And you might need a bit of pain relief afterwards, usually for the day, but the next day should be all right. My preference is to use antibiotic drops. You drop it directly into the ear for about 5 days after the surgery, although that might vary with different surgeons. And normally, and once again, my preference would be to see the child back in the rooms and get post-op hearing test done to see, well, from bad hearing to good hearing, and give us that reassurance. And normally, my follow-up plan would be to see the child 2 weeks after surgery, and then 9 monthly after that, until the grommets are dislodged. There are hundreds, there are different types of grommets available. This is just to show you a range of them. For me, I like to use the box standard ones, like these ones here, starting off in the first incidence, and then see how it goes. Grommet generally lasts for about 6 to 12 months, sometimes longer, sometimes shorter. But if you look at the bell curve, bulk majority of patients will retain their grommets for about 6 to 12 months. There are bigger grommets that we use as well. There's in cases where a child has had recurrent grommet insertion, and the bigger grommets will stay in for a longer period of time. But it does have its downsides as well. And the last type of middle ear infection that results in chronic foul-smelling discharge from the ear with hearing loss, you should be suspicious of something happening beyond all that pus. So the primary aim is to mop out all that pus using either tissue spearing or antibiotic ear drops or ear wash. In the end, hopefully you will be able to find the culprit, which is very often, most commonly, a perforation in the eardrum that you can see there. So this is a very unhealthy looking eardrum, which is that disc once again with the hearing bone in the middle, but lots of scarring, probably from previous infections or previous surgery, but then perforation sitting there. So very often you might get water getting into the ear, causing that infection, and therefore get that chronic discharge in the ear. So if you have a child that has a chronic foul-smelling discharge with hearing loss for more than 6 weeks, see your GP. I thought I'll throw this in as well, nosebleeds. I see a fair amount of nosebleeds in my practice. In little ones, it is usually what we call anterior nosebleeds, so it's dripping around from front. In a more elderly population, you might get posterior nosebleeds, you have lots of blood dripping around the back. So in kids, it is a little bit easier to manage. Usually, the main culprits are sitting in the nasal septum, in the litmus area, and therefore, when the little finger goes up, it traumatizes the septum, and therefore you end up with a bleed. Of course, there are other factors as well, like allergies or inserting a foreign body up there, or even temperature changes. When you get dry and crusty, a lot of kids tend to bleed a little bit more. What do you do when it happens? Don't panic. A lot of you do that, some people do that, but as you can see, cross, not ideal. The reason for that is because when you put your head back, you swallow all the blood. And therefore, as a preference, we squeeze the tip of the nose, head forward, so the blood drips forwards. Of course, sit down, stay calm, compression for about 5 to 10 minutes, that tends to stop it. You can use ointment, you can use your purple ointment, your Vaseline, whichever is your preference, or you can get antibiotic ointment from your GP. If it works, you can keep doing that. But very often, if it becomes excessive or it becomes too frequent, you tend to want to explore a little bit more, and this is where I end up seeing your child and with a view of cauterizing the nose. Most kids need cautery under general anesthetic, unless if you get an older child who's really brave, we might be able to do it in the rooms. Another big problem in little ones, tonsils and adenoid. Tonsils are the bits on the sides, as you know, not that dangly bit in the middle. That is the uvula. And adenoids is similar to tonsils. It sits right at the back of the nose. They're exactly the same type of tissues, except in different locations. So problem number one with tonsils, tonsillitis. It can be bacteria, it can be viral. Very often it's difficult to tell clinically what sort of infection it is. But regardless, the presentation, the symptoms, they're more or less the same. Sore throat, as you can imagine, when your throat is sore, you don't really want to eat. Sometimes you might get a temperature, sometimes you might get neck swelling. That's from reactive lymph nodes in the neck because it filters out the tonsillitis. And you might get ear pain as well, the referred pain shooting outwards. That's because of the same nerve supply. So once again, you do the sensible thing, encourage fluid intake and go on a whole regime of paracetamol and ibuprofen, keep it rolling, see how it goes. If it works, wonderful. If it doesn't work, this is when you need to see your GP once again, get some antibiotics on board. So normally, broad spectrum antibiotics for about a 7-day course, it works, settles the symptoms down. If it becomes excessive or too severe, you might want to explore your GP about, once again, getting a referral. There are guidelines, there are figures that we go by that guides us along as to when the problem becomes too excessive. So if the tonsillitis is only for a year, the guideline says maybe 7 episodes. If it's for 2 years or more, it'd be 5 episodes per year. If it's 3 years or longer, you'd be talking about 3 episodes of tonsillitis per year consecutively. This is a guideline. There are modifying factors that we look at. That would mean the amount of pain, the amount of antibiotics, the amount of time off school, and the amount of time you have to take off work to look after your child. So all these modifying factors that would influence us in decision making. You don't necessarily need to have 7, but all these factors we look at and therefore discuss a plan with you. Rather than tonsillitis, I deal more with obstructive sleep disorder. I see more kids with obstructive sleep issues needing surgical intervention as opposed to tonsillitis. Normally, the frequency of tonsillitis in kids are not severe enough to say we should take it out. But obstructive sleep disorder, on the other hand, it is more of a problem. Very often there's a misconception, my kids don't get tonsillitis at all, so why should I be bothered with this? There are in fact 2 different pathologies affecting the same area. So obstructive sleep disorder is a whole range of presenting symptoms going from simple snoring or heavy breathing all the way to sleep apnea. Sleep apnea is when your child stops breathing for 10 to 15 seconds or more. Now honestly, most kids that I see are not that severe. They'll be falling somewhere in between. So you'll be wondering what are the symptoms to look out for. Snoring, heavy breathing would be a most obvious symptom because you can hear it when your child is asleep. Normally, because of the obstruction, they'll be sleeping with their mouth open, and normally they prefer to hang backwards because it creates a bit more space. But for little ones, they might prefer this. Lying on the belly, bum up in the air, let everything hang forward. So once again, you get a little bit more space. And usually, you might get a child that's really restless, tossing, turning. You might hear short pauses, snoring goes quiet for a few seconds, and it restarts. Some might end up gasping, choking, or snorting. So all these are symptoms to look out for. They are restless because they're trying to find a more comfortable position to sleep in. And because of that, a lot of times they wake up all the time. Disrupt their sleep, disrupt your sleep. And because of the constant disruption and not going to their deep phase of sleep, They could end up with nightmares. They can end up with night terrors. Some will do sleepwalking. Some will do sleep talking. It's all a bit weird. I have a child that does sleepwalking for a couple of nights consistently, go to a green couch in the house, and does wee-wee in the house, on that couch. So be on the lookout for that. Other things that you can look out for, the kids will generally be a little bit hot, might be a little bit sweaty. They might end up wetting their bed. So all this constant disruption then impedes them from going into the deep phase of sleep. So as you can imagine yourself, when you sleep poorly every night for God knows how long, could be a prolonged period of time, you end up with a child that's easily tired, they're irritable, they're grumpy, they end up with behavior problems, they could be hyperactive, sometimes misdiagnosed as having ADHD. And all the kids are picked out a little bit later might end up with concentration problems. They start doing poorly at school. So it's important to look out for symptoms. And if you have noticed symptoms, it would be important to look out for consistency of symptoms as well. If it's only once a month, no big deal, relax, do nothing more. But if it's happening a couple of nights a week, this is where you start to raise a concern with your GP. You can revert back and have a look and see what you can find. Knowing where to look would be to see this. Unfortunately, we cannot see the adenoids. It's hiding right at the back. And normally I do not need an x-ray at all because it goes by symptoms, but I happen to have one, so I thought I'll show it to you, and that's exactly where the adenoid would sit, right at the back of the nose. Big clump of tissue, similar to tonsils, it looks like that. So while discharged and having surgery, took a picture, just for the benefit of presentation, so you know what it actually looks like. So between the two nostrils, at the end, they join into one, becomes one big hole. And that big hole should be patent, but as you can see here, big clump of tissue, blocking off that hole. Tiny little bit of space to breathe, which is why Clue is a constantly congested, snorty child, full of mucus, sick looking all the time, lots of coughing, most of coughing at night, because that mucus that's trapped in front of the adenoid tissue tends to drip backwards. They have a hole here of postnasal drip. When that goes down, irritates the throat, lots of coughing. And therefore, that gives us a clue. But yourselves, big look in there, see what you can see. Obviously, not every child is going to be like that. It's quite dramatic. So then you start to think about what is big and what is small. And therefore, we grade tonsils. We grade tonsils according to sizes, from 0 in the child who has previously had their tonsils out, all the way to grade 4. That's the biggest it can get. Sometimes I get a referral from a GP that says grade 5. I wonder, what's going on here? But grade 4 is maximal. They're touching, they're kissing tonsils. Of course, correlation needs to be made between tonsil size and symptoms. You might get a child with big tonsils and not have any symptoms at all. So over the last couple of years, I met 1 or 2 kids with massive kissing tonsils and completely asymptomatic, which really baffles me, but it does happen. Besides the above 2 reasons, there are other reasons why we take tonsils out as well. So there's some sort of definite indications and there's relative indications. These are not as common as what I talked about, but as you can imagine, kids with big tonsils, sometimes when they try to swallow, it can get difficult. You might get a child who's really fussy with what they want to eat. They might want to avoid meat. They might end up choking or gagging when they try to swallow. Some will try, but end up continuing chewing for a long period of time and not swallow. And as a result, if they don't sleep well, they don't eat well, they don't swallow well, you might get a child that's slightly underweight for their age, a failure to gain weight. And if you have big tonsils sitting at the back of your throat, sometimes you might get speech issues, you have loss of clarity. Increasingly, the dentists or the orthodontists have been recognizing the impacts on the hard palate from a child that's chronically obstructed. Maybe a child with a narrow, high arch palate that comes together with obstruction, and therefore I get a lot of referral from pediatric dentists, in which you check out this child's airway because we're planning to insert a palatal expander. And then you'll be talking about bad breath and tonsil stones. Of course, If it's really severely infected, you might get kids with abscess formation or quinsy. Malignancy, I treat in there. It is very, very rare in kids, but it can happen. But all these are possible reasons. This is why we think about taking tonsils and adenoids out in kids. How I like to take tonsils out. I thought you might be interested to know as well if you come to that stage. There are many, many different ways to take tonsils out. Once again, it boils down to what the surgeon prefers. What I like to do is what we call a coblation adenotonsillectomy, meaning taking tonsils and adenoids out together. It is a radio frequency surgery, which is moved on from this, which is an older version, to that. So it utilizes an electrode array, which is right at the tip of that one, the magic one that takes out the tonsils, right there. The electrode array uses the fluid in here that flows down the shaft, causes a plasma field to form around that electrode. So that plasma field then dissolves tonsil tissues at a very low temperature, between 40 to 70 degrees. Other methods like electric diathermy, I don't think anyone uses laser here, but laser, they go up to 300 to 400 degrees. So the advantage of me using that is it gives you a more precise dissection, but given the low temperature, you get less surrounding tissue damage and get less tissue damage deep down into the muscles that lies beyond the tonsils. And therefore, the advantage is less post-operative pain waking up from the procedure. But unfortunately, pain is one of the things, regardless of what you do, whether you take them out with coblation or put them out with fingers, pain is still going to be there. It's unavoidable, but it just gives us that head start for that 5 to 7 days immediately after the surgery. So think about the surgery, which is once again a general anesthetic procedure. If we take the adenoids out alone, it is less impact on your child. General anesthetic, day case, stay around for 3 hours, you'll be on your way home. You go on a pain relief, generally your Panadol and Nurofen for a few days, antibiotics for 5 days, and generally you bounce back much, much quicker. Taking tonsils out then would require overnight stay. One parent can stay overnight, and once again, longer pain relief, longer regime of pain relief, different types of pain relief, antibiotics for 7 days, and be prepared 2 weeks to get better, and that's the challenging part. Let me talk about what happens on the day when you get there. Besides walking down a lot of long corridors, you need to look for the admissions department, obviously. Some corridors are better than others, but ours is not too bad with lots of pictures along the way. So look for the admissions department. For the anesthetic side of things, I'll leave it to Dr. Heaney. But this is what you see when you go out to the ward. So this is our pediatric ward. We try to make it as bright and colorful as possible, so it'll be less stress for the kids coming in. So you see the nurses, you go through the history, the medications, the allergies, check the consents. But prior to getting here at home, you would have done the online admissions. You do it yourself at home, giving basic information. And then you wait on the ward. You can run around, you can play with the toys. Not you, but the kids, and wait for a pickup by the orderlies. So when the time comes, the orderlies will come pick up the child and one parent, and you see this door. You wonder what goes on in there. Here's your chance. Not too exciting, unfortunately. So you see more nurses to check you over, check the name band, check the consent. We park you in a pediatric bay. Once again, we hope will reduce the stress of coming into the hospital. Because it gets weird. Everyone's in blue and we wear funny hats. This might set in. Once again, I'll leave this to Dr. Heaney to talk about. And then when your time comes, you'll be walked down or pushed down into the operating room. You see more people. In fact, quite a lot of people in the operating room. There's me, there's the anesthetist, There'll be a technician helping the anesthetist. There's usually 3 scrub nurses, and usually I have a medical student with me as well. And then you see all sorts of equipment there. You got bright light, you got microscope, you got all sorts of gear, the spaceship for the kids, and the bed. And there's Dr. Heaney in the background. Once again, I'll leave this for later. No needles, right? So there's no need to mention needles to your child. You only stress them out. In fact, we don't use any needles while the child is awake. And after the operation, you wander off from the operating theater and theater recovery. And this is where you see the recovery nurses doing observation on your child, taking their odds, making sure they're okay. Normally, your child will be awake when you see them in theater recovery, but they're not fully aware what's going on. They're still half awake, half asleep, having a party with the fairies, but eventually within 5 to 10 minutes of you seeing them, they should be fully awake and hopefully having their eyes open then. And then we reward them with a bravery certificate. Nearly there, right? And you go from theater recovery all the way up to the ward. Some of you might have seen this before. You're back to your room, check out the menu, feed yourselves, and you should be on your way home. Thank you. I'm going to leave the next part of the talk to Dr. Heaney, my esteemed anesthetic, pediatric anesthetist, one of the few unique ones in the state where she does pediatric ICU and pediatric anesthetic. I put up with her for the last 8 years. And I put up with her for good reason, because she's excellent. Thank you.
Thanks, George. Thanks, everybody, and thanks for coming this morning. I put up with George as well. Probably some of the nurses in theatre think we act like a bit of an old married couple, but we know each other so well. We work together so closely and so well, and anaesthetists and surgeons really need to communicate and kind of know what's going on in each other's heads. So that's why we sort of are like a married couple a little bit, just in work though. So I wanted to talk to you this morning about your child needs an anaesthetic. What should you expect? Now, just a little bit about me. I'm a consultant anaesthetist and intensivist at Perth Children's Hospital. I've worked there in PMH as a consultant for the past almost 15 years. Prior to that, I worked in intensive care at Royal Perth Hospital. And prior to that, I trained for 7 years as an anaesthetist in Ireland after my 6 years of medical school. So anaesthetists are highly trained specialists who are ready to look after your child. I'm also talking to you this morning, though, as a parent. I'm a parent of 4 children, and all 4 of my children have had to have tonsillectomies for sleep disorder breathing. So I've been on both sides of the equation. So anaesthetising children is much different to anaesthetising adults. Many of you may have had anaesthetics as adults, where you'll come in, you'll lie nice and quietly and obediently on the bed. But children are not like that. It's a different story often. So like I said, an anaesthetist is a specialist doctor who'll give your child their general anaesthetic medicines that they need to have during surgery, and we monitor your child extremely closely. Many parents ask me, is it safe for my child to have an anaesthetic? Well, first of all, your child is not going to be having an anaesthetic unless they need to have the surgery. They're not coming in having cosmetic procedures done. They're having an anaesthetic because they need surgery to improve their quality of life. So in one word, yes, your child will be safe having an anaesthetic. There is some animal evidence that really high dose prolonged anaesthesia can affect the brains of animals under kind of 4 years of age, but there's no evidence in humans that short brief anaesthetics have any detrimental effect on a child's neurodevelopment. And I'd say to parents and to children, you're never as closely monitored as when you are anaesthetised. We're literally looking like Sting at every breath you take, every beat of your heart. This is a child I anaesthetised yesterday for an MRI scan, and you can see all the different things we monitor while you're asleep. Your heart rate, we don't have a heart tracing on there because you can't do that in an MRI scanner because it's magnetic. So we monitor your oxygen saturations, your breaths, how deeply you're ventilated, your blood pressure, how deeply you're anesthetized, so that we always know the patient's not aware, they're completely anesthetized and not aware of anything that's happening. So you're very, very closely monitored from the second we anesthetize you until we bring you safely to recovery to be recovered with the recovery nurses. And many parents also ask me, it's not fair, why does my child need to fast before surgery? Well, the reason anybody needs to fast before surgery is when we anesthetize you, we remove your cough reflex and your gag reflex that would protect your airway. So if you have a full stomach and you're anesthetized, if you vomit, you're not going to protect your airway. There's the risk of all those food contents going down your airway into your lungs, causing pneumonia, and worst case scenario could potentially be fatal. So it's extremely important that everybody fasts before elective anesthesia. And I find it's much kinder as a parent if you fast with your child as well. You wouldn't believe the number of parents who come down with their child and they're drinking on a coffee, or we've even had parents eating bags of crisps in front of a starving toddler. You know, it's not fair, and it's good if you share the experience and go through it all together. And as anaesthetists, we really try to minimize fasting times for our children. So your anaesthetist will call you the evening before surgery and give you specific fasting instructions and admission time for your child so that they don't fast any longer than the safe minimum. If you're an infant under 12 months of age, you can actually have breast milk up to 3 hours before the surgery time, formula 4 hours before surgery, and then all other foods 6 hours. But we allow clear fluids for everybody up to 1 hour before the surgery. And clear fluids is water, clear apple juice, lemonade icy pole. It's not jelly, it's not chewing gum, not lollies, not milk. And how do you prepare your child for surgery? Well, what you tell them really depends on their age. You will be sent an information leaflet by your anaesthetist. Your surgeon will go through with you beforehand what the surgery entails. And it's really important as a parent you read through all of that and you're familiar with it, and then you can explain it to your child at an appropriate level for their age. Generally, we would say if your child is over 6, you should start talking to them about the procedure and the anaesthetic 4 to 5 days beforehand. Younger children, probably tell them 2 to 3 days beforehand. It's good to tell them the truth about what's going to be happening. You don't need to tell them everything, but really don't lie to them. That is don't tell your child, and we've had this before, you're going on a cruise and then they wake up in pain and they're not, what kind of cruise is this? Or you're going to stay in a lovely hotel. They won't trust you. It's really important to be honest with them. You don't have to put in all the detail, but just don't lie to them. Don't tell them you're just going to sleep, because then they may think every time they go to sleep again, it'll mean surgery. And also what children fear depends on their age. So little children under age, 5, 6, will fear being separated from their parent. So it's good if you tell them you'll be coming with them, staying right until they're asleep, then you'll wait till they're in the recovery room and you'll be there as soon as they wake up. Older children fear, their body parts being exposed. They fear that they might wake up during the anesthetic, that they might feel pain. So it's really important to alleviate all those fears. And if you're anxious yourself, children can really sense parental anxiety. And you may have read, in the media, there seems to be a massive increase in the amount of anxiety in the population as a whole. We've noticed that more and more children seem to be very anxious coming for surgery, and a lot of their parents are more anxious as well. I know it's a really stressful day and experience, but it's really important that you try to stay calm. Remember, your child is having this surgery done for a very good reason. They will be safe, but it's normal for you to get upset, but just try to stay calm. Now, your child can bring any comfort object they like to hospital, their dummies, teddies. They can keep their dummy in while they go to sleep. They can wear their own clothes if they wish. The hospital here likes to put hospital pajamas on them, but if they really don't want to get into the hospital jammies, and a lot of toddlers don't, it's fine that they come in their own clothes. Very important as well to tell them you'll be there till they're asleep and there when they wake up. And as George said earlier, don't mention the N word, because really at all ages, most children are terrified of needles. You don't need to we call it a little plastic straw. Most of the time we'll put the drip in when the child is asleep. So there's no needles or anything like that. And that often is what most children fear about surgery. Not about the pain or about waking up, it's about the needle. So it's really important on the day of surgery. So I told you I'm a parent of 4, and all 4 of my children have had surgery for sleep disordered breathing. And the one thing I can tell you is every child is completely different. So you may have gone through it before with one of your children, but your other children will be different. So it's important as a parent you keep them relaxed on the day of surgery. They know what's happening. My children were abnormally excited about going to hospital this is on the way to hospital to get their tonsils out. They didn't look like that coming home, but they were excited on the day. When you get to the hospital, they can generally, play in the playroom with toys. Important to keep them relaxed all the time. They can bring as many, to maybe not quite this much, but bring all their teddies and comfort objects, and they can come into theatre with them and stay till they're asleep. When they'll get numbing cream on their hands, even though we generally don't use that to go to sleep, but say if a child freaked out when we show them the mask, there's the opportunity for us to put in a drip painlessly with distraction, so that's why the numbing cream is there. They often don't like being in those hospital gowns, and they can stay in their own clothes if they wish. So most children, especially when you're having tonsils out, you will have a drip put in, generally when they're asleep. We do put on the numbing cream, and we can distract them and put the drip in. It is a tiny little needle we put in, but that is taken out and a plastic straw is left in. We stick it down really well, especially for tonsillectomy, because it has to stay in overnight. A lot of toddlers don't like having something like that attached to them, so I will generally put it in their foot where they can't see it, so their hands are free to eat and play after. It's a good idea as a parent to maybe bring some socks with you so that can be covered up. We give them lots and lots of fluids while they're anaesthetised, so then the drip is not attached to anything afterwards. It's wrapped up in a bandage, they can't see it, and they can walk around on the ward after. It's not a problem. If we do get your child to go to sleep with a little drip, it takes a few seconds for the child to go to sleep that way with medication through the drip. It can be very upsetting as a parent when you see that, because 1 second your child will be sitting up, and a couple of seconds later they'll be limp and floppy, and that can be really shocking as a parent and upsetting. So it's good to be prepared for that. Otherwise, what we generally do for children is we go to sleep breathing through a mask. So for little girls often like to call it a fairy mask, and we put some fairy dust through the mask and they see fairies when they're asleep. Little boys like space masks and girls like space masks as well, but we pop the mask over their mouth and nose. They breathe some laughing gas initially, and that helps them get a little bit giggly. Then they breathe the sleepy gas and they start to drift off to sleep. It takes 1 or 2 minutes to go to sleep this way, and you'll see your eyes will start to roll back in their head. They may wiggle, they may snore and have noisy breathing. It's really important to remember that that is normal. It's not them struggling, it's not them fighting against the gas. It's a normal part of going to sleep with gas. Gas makes muscles move on their own, and your child won't even be aware of it. Then we'll lift your child up onto the operating theatre bed, and a nurse will show you out to go and get a coffee, and literally you'll barely have time to drink the coffee and you'll be called back into the recovery room. So this is just one of my children getting the numbing cream on. They kind of like playing with that. It's nice and squishy and leaks out everywhere. And then when your child is going to sleep with gas, obviously if they're 10 or 11, you can't hold them on your lap, but up to age probably 5, 6, especially little babies and toddlers, it's really good that they go to sleep on your lap. So they'll sit on your lap, you'll give them a nice tight cuddle, we pop the mask on and they drift off to sleep. If we want to put in a little plastic straw, again, they can sit on your lap, play on an iPhone, and then we'll do the little drip without them seeing anything. What about if your child is anxious? And many children are anxious. So explain to them, what will happen. Explain that there'll be no needles. If your child is really anxious or uncooperative, we can offer premedication, which is a little drink to have up on the ward. So the drinks can be given in a sip of apple juice or lemonade. Some of them, there's different choices, but some of them will work within 20 minutes, others within an hour, but they can help facilitate your child going to sleep more smoothly. We don't routinely use pre-meds, and that's because some of those medicines can make your child wake up more upset after the anesthetic. So if your child is generally cooperative, we don't recommend a pre-med, but certainly for anxious children, it can really help take those nerves away and make everything go more smoothly. The most important thing is calm parents. And calm parents coming into theatre with their child, it can be a really good experience and a really good bonding experience for you as a parent with your child. If your anxious child is on medication usually, take their usual medication the morning of surgery. There's lots of really useful resources on the internet. This is from the Children's Hospital in Melbourne, where you can do exercises with your child to stay calm around the time of surgery. So the key points, general anesthesia, which you will need to have all ENT surgery, is a mixture of medicines given to your child to keep them asleep during surgery. Your child can go to sleep 1 or 2 ways, through a drip, or most of the time we'll give your child medicine through a mask to go to sleep, and then once they're asleep, we'll put in the drip and give their other pain medicine, fluids and anti-nausea medicine. You will be there with your child, staying till they're asleep. Your child will go to recovery after surgery. I won't leave them in recovery until I'm happy that everything is stable, and the nurses will call you to be with your child as they wake up. So they will have no memory of you not being there. The breathing tubes removed at the end of surgery in the operating theatre or often in the recovery unit. Your child won't remember this tube coming out, but they might have a bit of a sore throat afterwards or a croaky voice. And remember, your child will have a drip with a dressing over it, and it's good in older children to tell them to expect that. So the nurses will call you. You'll probably still have your coffee, but you'll be there with your child to wake up. Not so much here, but if your child has more major surgery, they will go to the Paediatric intensive care unit after surgery. When you see your child first, it can be a little bit confronting, because even though they'll be awake, they can often look a little bit spaced and vacant and not sort of really seem to see you or know you're there. They'll be having an icy pole often. She doesn't look like she's enjoying it. This one's a bit happier. So, you know, when you get the thumbs up after, it's good. There can be issues after anesthesia. And pain, nausea and vomiting. Ear, nose and throat surgery is one of the types of surgeries that you can get nausea and vomiting afterwards. But we give 2 different types of anti-nausea medicine when your child is asleep, and they'll get fluids while they're asleep as well. I'll talk about the pain after tonsillectomy in a minute. You may notice some bruising at the IV site. And sometimes if you have a really chubby toddler, they can be hard to put a drip in, and it could take a couple of goes. So you might see a few little bruises, but just the thing to remember is they're fast asleep when we're doing it. They're not feeling any pain, but just you might notice a few little bruises afterwards. Emergence delirium is really common in preschool children having short, non-painful procedures, especially at the toddler. Having a grommet is the prime candidate who is likely to get emergence delirium after an anesthetic. Emergence delirium is when you come into recovery. Well, you might be outside recovery and you might hear screaming and you're going, who is that screaming? And then the door opens and you're like, oh, it's my child screaming. And their eyes are open, but they don't see you. They're awake, but they're not really awake. Their little brains aren't able to process why they feel dizzy, groggy, and strange. So they can wake up really upset afterwards. Really important to remember is they're not aware of it, they'll have no memory of it, it will have no long-lasting implications, but it can be really upsetting for you as a parent seeing it. We do everything we can to try to prevent it. There's medicines we give while your child is asleep, and we can give more medicine in recovery to make them go back to sleep, but it still can occur afterwards. Children can get sleep disturbance after the whole trauma of surgery, anesthesia, hospitalization. So they may have been sleeping through the night and then suddenly you go home after your surgery and they start waking up again at nighttime. Night terrors can occur afterwards. Bedwetting. Some children can regress temporarily in their milestones. One of my children had her tonsils out at age 3 and afterwards she stopped talking. She wouldn't take any pain medicine. So I was running around after her like that cartoon at the start for 2 weeks trying to get suppositories into her. But she stopped talking and started babbling like a baby. It all went back to normal afterwards, but all these things can be, you know, quite frightening, but they are rare. Most children will have their surgery and recover really well and there'll be no problems. But it's important to know that these things can occur. They do all resolve most of the time within a week or 2, but sometimes, very rarely, night terrors and waking at night can last for a month, but rarely. It is really important to understand that general anesthesia is really safe. There's no evidence that it causes any developmental issues with your child's brain development. And probably if your child is having sleep disordered breathing, their oxygen levels are dropping really low at night time, that very fact affects them much more than having an anesthetic. So everything we do is risks versus benefits. So the pain post-tonsillectomy is significant. It's different to other types of surgery in that it can get to its worst day 5 to day 10. You know, when you think this pain should be getting better, suddenly your child is now waking up at night in pain in the middle of the night. So day 5 to day 10 can be quite difficult. It generally settles around day 14, but like I said to you, every child is different. Some children need no pain relief after the 7th day, and some children need pain relief for more than 14 days. We give regular paracetamol, regular Nurofen, and then a stronger painkiller called oxycodone that you can give for breakthrough pain. It's a really good idea to do a spreadsheet, because you'll be giving antibiotics, ear drops, pain relief at multiple different times during the day, and it's a good idea to stagger them. So having a spreadsheet where you can tick off your doses, because if you're like me, you know, forget or miss them, so it's a good idea to have that all on paper. Chewing gum is really good for bigger children. It really helps with that chewing, swallowing. That's really good for pain relief. And I put down lactulose at the bottom. Just if your child is needing a lot of the oxynorm, it can cause constipation. And I found, you know, one of my children ended up having to have suppositories because they hadn't pooed in 2 weeks. So lactulose is a good idea to get on board early if you feel your child does have pain issues, because every child experiences pain differently. Some of us have lower pain thresholds than others. The pain is real, so it's really important to get, you know, on top of that. And every child is different. This is one of my children having a burger a couple of hours after having had her tonsils out. Little did I know that this was the last thing that she would eat for almost 2 weeks. She refused to eat because she said everything tasted like blood. But then my other child, who had the exact same surgery, the same time, the same pain meds, this is her having her scratchy, crunchy cereal the next morning. She barely needed any pain relief after day 5 and ate everything. So every child is different. Some children breeze through it, and for some children it is, you know, more difficult. I found myself having siblings, having your 2 children go through it together. For me, with these 2, that was easier, because it does take 2 weeks out of your whole family's life. They're off school for a week, and then they may be sore for the next week. And they were a really good support for each other, and it just made it easier to do 2. It was hard, but it was easy to do them both together. So that is it. Are we going to have questions?
I'm sure. Wendy? So if you have any questions, surgical, anesthetic, or logistics, ward, admissions, feel free.
My daughter, my 8-year-old's got some growths in her nose. I think on one side she's got, I think it's turbinates or nasal polyps, and the other side's almost joined, and she can't breathe. Can you talk to me about the procedure that much?
Yeah, so very often in kids, you'll be talking about the turbinates, which is pretty much the side wall of the nose that then goes down the sides. So we look up the nose, it looks big, cherry red, light swelling. Very often it gets mistaken as a polyp. Nasal polyps can happen in kids, but they're very, very rare. So these are kids with respiratory issues. So more commonly, you'll be dealing with the turbinate structure. A common culprit could be allergies. So depending on the age of the child, if there's any specific aero allergens, meaning your dust mites, grass, or animal hair, they could get an enlarged turbinate. So the first thing you can do is to try some saline nasal sprays, or if the age is suitable, you can get a steroid-based nasal spray as well, but very often have a good chat with your GP. But those will be the first steps that you would take prior to thinking about surgical intervention.
She does do the antihistamines, the steroid drops, and the nasal mix, but it's still not reducing.
Yeah, so if that's the case, it becomes a problem. It impacts on the quality of life, meaning sleep or daily, running around or sports. Then this is where we start to chat about what to do to the child. There are different surgical options available depending on the age of the child itself. So basically 6 years onwards, I do a turbinate reduction surgery, which is a pretty fancy submucous resection of the turbinate structure, reduce it in its size to about 1/3 its size, and therefore provide good nasal passage, so breathing through the nasal passages.
Yeah, and if the septums, like there's no...
So kids who are growing in a developing child, almost certainly I don't deal with the septum at all. Not because it's not a problem, but it does impede on the mid-facial growth. So in a growing child, we rather ignore that problem and do what we can until the child is fully developed to about 15 or 16, depending on the age of how well they grow.
With the tonsillectomy, I know I had mine out as a child, and then 25 years later they grew back. So the second time I had them out, they did it a different way to make sure there was no tonsil tissue remaining, so they would hopefully not grow back again. With the method that you use, is there a likelihood that they may grow back?
So there is tonsillectomy, where we remove the whole tonsil altogether, and then there's tonsillotomy, where you remove part of the tonsils. There's pros and cons with each. With the tonsillotomy, the rate of bleeding, the degree of pain is a little bit less, but always there's a chance of regrowth. So what I do is a tonsillectomy. From what I see, more or less the same in terms of pain and recovery, which is why I prefer to remove the whole tonsils altogether, and therefore almost no chance of the tonsils growing back.
If my child's constantly having sneezes and blocking runny nose, and sometimes he wakes up tired during the morning, we've been to GP and they recommend us to do some allergy tests. Do you know at what stage we should be seeing the specialist?
So once again, depends on the frequency of the symptoms. If it's really, really frequent on a sort of couple of nights a week, and surprise it's not working, and an allergy blood test is really not that exciting, have a chat with your GP, send your child in, get a basic assessment done, and then we can sort of examine your child and see whether there's a problem that we need to deal with or not.
Is there any chance the adenoids get shrunk by themselves?
Eventually they will. So when you reach your teenage years or as a young adult years, it does tend to start to regress. So they go through a phase between ages of 18 months, 2 years, after about 10 years where they get a little bit bigger, the growth phase, stabilize for a few years, and then they start to regress. But then very often in kids, the problem is very often causing problems in the younger age group, so you tend not to wait till they're fully grown.
Is there any food we can avoid, like tonsils?
Of course you can put up with it, or you can use nasal sprays, your saline sprays, your steroid sprays, try and get all the mucus and snot in the nose and see what that helps. But very often that gets rid of the secretions, but it doesn't change the size of the tonsils or the adenoids. So this is where you start to think about the impacts on your child.
That's okay, you've answered it.
My daughter's got adenoids that are 75% blockage and tonsils that are 50%. They're recommending surgery, so I think they'll be going through it. But one of the little girls in her kindy class had it done and she had a bleed that night where they had to take her back. Are there any other complications than that, and what are the other signs to look for post-operative for any other complications that may occur?
So one of the things that would be what Murray talked about would be pain. Pain is usually something that you need to deal with daily. It can get intense. Very often it depends on the child. So that's a primary concern. Bleed is unavoidable regardless of what procedures we do. Any surgical procedures, you run into a risk of complications, and bleeding is one of them. It's quoted as 5%, which is on the higher side. In kids, it's about 3% chance of a bleed over a course of 14 days. So you have primary hemorrhage, which is bleeding in the first 24 hours while you're in hospital, or secondary hemorrhage during that 14-day recovery. And that has been quoted as between 3 to 5%. Unfortunately, there's no way of preventing it, and there's no way of predicting who's going to have it and when it's going to happen. So the best thing that you can do for your child is to keep up the pain relief, regular pain relief. As long as they're eating and drinking reasonably well, you minimizes the chance of that happening.
Should it occur, what is the best procedure for the parent to do at the time, at home?
Well, don't panic for one. Generally, it is enough to give you a fright. You will panic, but stay calm. If you get flustered, as Maret says, your child would react in the same way. If you're comfortable enough that the bleeding has slowed down, you can sort of drive your child down to the nearest emergency department. Or if you think that, well, this is something you cannot deal with, of course, ring for an ambulance. But not the good thing, but the positive thing is usually after that massive hemorrhage, usually it slows down. And by the time you reach ED, most of the time it will stop bleeding. And from personal experience, I don't know, Mairead, have you encountered any other complications?
No, I mean the bleeding is the biggest one that people fear. So yeah, just important to be aware of it and take your child to PCH ED if they do have a secondary bleed. Or Fiona Stanley ED, if that's nearer.
My son is 5-year-old and he was diagnosed with large tonsils. But I feel that it doesn't affect his life. Should I keep on putting it off, like the surgery, or one day I will like make a decision and put,
Right. It depends on what sort of symptoms they're doing at night, the duration of them demonstrating those symptoms. Sometimes it can be subtle. Like I said, older kids, sometimes they can control their emotions. They don't lose the plot. Their behavior might be under control. But because they get tired, they can't concentrate that well at school. So that might eventually present that way, and they might have issues that way. And kids with sleep issues, if left unsorted, there might be a higher tendency of them continuing to get sleep issues when they become adults.
yeah, so maybe he has subtle. Is there a relationship between nose bleeding and tonsils?
No.
Yeah.
I just threw that in because it's quite a common problem. Yeah.
It's likely that our daughter has, or we've got sleep apnea in the family and whatnot, but she's been recommended for a sleep study as well as ENT. Is there an order? Do you see which one first?
It's always a question that we wonder. Sleep studies can be helpful, but you got to think about what happens when your child has a sleep study. So generally, you come into the hospital, about 5 to 10 monitors on your child, sleeping in a different environment. That might not go very well. So is it going to be accurate? Sometimes yes, sometimes no. And sometimes with mild obstructive sleep disorder, it might not truly reflect what's happening every night, because the monitors could be good, but your child is still symptomatic. Which is why I normally don't consider sleep studies for your box standard child that comes in without any other medical issues. It can be helpful if a child is syndromic, or if your child is really young, under 2, even under 1, I'm thinking, should I do this early or not? So sleep studies will help to support, well, it's not that bad, perhaps we can wait. Or in kids who are really obese with really at a higher risk of having issues and complications after surgery. So those are 3 scenarios where I get a sleep study for. But for a box standard normal child, we go by history, by examination, and very often that's sufficient. I mean, there's no stopping you getting a sleep study if you want, but then if your child is symptomatic and it's not truly reflective in a sleep study, which I see a lot, what you do, it confuses you even more. But there are certain expert sleep studies, which is why I don't get it for everyone.
Julia is asking, what is a polyp and how do you cure it?
There can be a lot of causes as to why you get polyp, whether you're a child, whether you're an adult, whether it's for yourself. There are a lot of factors. Allergy is the main culprit, so it can be due to that. The mucosa, the lining of the nasal surface is rubbing against each other. That could cause polyps. I mean, very much depending on the patient.
How do you tell if it's the polyp or a tendinite?
By looking at it. It looks different.
With large tonsils, does that affect eating? Like my son has larger tonsils, I've been told. I'm not sure what scale it is. We go back to our ENT next month to decide whether or not we do surgery. At
what stage would you recommend surgery? He has a few of the other symptoms, but one of the big ones, eating. He's a terrible eater. He does what you were talking about, where he chews a lot and then spits it out. He's quite small for his age as well, compared to all the other kids in his kindy class. He's tiny. So is that likely to help his eating if we've got the tonsils out?
So taking tonsils out for eating issues is what we call relative indication. There's more major indications like your sleep apnea and tonsillitis. So if he does have symptoms like that, then it's probably related to his tonsils. Seems like we're all good. Anything else?
Is it nose bleeding related to adenoids?
No.
Because she's having the most symptoms, but I'm guessing it's because of the large adenoid she has.
Well, let me put it that way. Adenoid doesn't cause nosebleed, but big adenoid sometimes leads to crusting. Crusting as it flakes out might cause nosebleeds. It irritates the child. They go like that. They go pick at the crust. But it's not directly related.
With regards to enlarged tonsils, does it make the lymph nodes raise? Like we can palpate it?
If it's from an infective cause, yes, because the lymph glands pretty much drain, filter out bacteria and viruses, right? So if it's due to tonsillitis, then it can be related. When kids in there, so sometimes yes, sometimes no. You're just going to monitor, see whether they enlarge it, whether they get they enlarge as time goes along. If they do, then sometimes we get ultrasound for that.
He had an ultrasound done, and they said it's just like to monitor, but now it's having like tonsillitis cost.
Yeah, so for little ones like that, it could be all sorts. It could be the ears, it could be the chest, anything upper respiratory could cause that.
Our daughter, she would get 3 lots of tonsillitis a year. Doesn't seem to worry her too much, but she does get a little bit sick with it. But she ended up with a retropharyngeal abscess, I don't know how to pronounce that, about 18 months ago. Is that likely to have been caused by the tonsillitis?
There's a high likelihood, yes, but then any sort of upper respiratory tract infection could cause that as well. Yeah. So the retropharyngeal abscess comes about because there are lymph glands in that area. The retropharynx meaning what you can see beyond the throat on the inside. Yeah. So that gland gets really infected, becomes really bad, and therefore you get abscess formation there. Yeah. But tonsillitis is a known cause.
Yeah.
Yep.
I have a 6-year-old who has like nasal blockages at night, on the nose side, where he has a stuffy nose, and like luminal or coughs because of the back throat. Could be allergy related. Is it worth getting checked?
So once again, like I said from previous slide, sometimes in that sort of age group, the adenoids can be quite big. It could be a combination of allergy and large adenoids. Once again, if it's consistently there, not settling with your usual saline drops and antihistamines, and try all sorts conservatively, then it's worthwhile getting your GP to write in a letter.
If it is an allergy and the whatever non-surgical things that you're doing, will it reduce eventually?
If you treat the allergies, will they get better? Not all the time. So there are kids that undergo a desensitization program with the immunologist, and about 50% chance of it clearing. And that's by chatting with one of the pediatric allergists. What's the success rates of working? About 50% chance. Oh, good. Thank you.
Thank you so much.
Yeah.